Hi everybody. Sorry we're a little late here, a minute or two of technical difficulties. I am Dr. Jamie Mitchell. I am an endocrine surgeon and the medical director at the Norman Parathyroid Center in Tampa, Florida, where we do all of our operating at the building you see behind me. A beautiful facility, a one-of-a-kind hospital called the Hospital for Endocrine Surgery, dedicated entirely to the care of the endocrine surgical patient. A place that I feel really fortunate to be able to work at. We're going to do a little live question and answer session about parathyroid disease. We do these about every 6 weeks for those of you out there who want to join us in the future. And I'll go through my background here just for maybe a minute to give some people a chance to join. I grew up in a small town in Maine, actually, and did my undergraduate studies at a small but excellent school in Massachusetts called the College of the Holy Cross. I was a biology pre-med major there and went to medical school at Georgetown in Washington, D.C. I knew pretty early I wanted to be a surgeon. That was obvious to me, and I was fortunate enough to do my training, general surgery residency training at one of the Harvard hospitals in Boston. I was there for 7 years, and then I did a fellowship in endocrine surgery at the Cleveland Clinic, where I stayed as an academic surgeon for about 8 years before joining this practice just over 10 years ago. That's a little bit of my background and my 16 years of education and training. And let's get started with the questions. We already got quite a few pretty good ones, so I'm going to get started. You, of course, can submit some while we do this. If we have time, we'll get to them, okay? So the first question I have is the following. Is there a link between Hashimoto's thyroiditis and primary hyperparathyroidism? It's a good question. For those of you who don't know, Hashimoto's thyroiditis, the technical term for that is chronic lymphocytic thyroiditis, and probably the most common reason for people out there to have an underactive thyroid gland. The answer to the question is no, there is no causative relationship between that condition or autoimmune thyroid disease and hyperparathyroidism. Some people think that it makes the technical aspects of the surgery more difficult when you operate on people for parathyroid disease who have Hashimoto's thyroiditis. I don't personally think that it's a big deal, to be honest. So, short answer, no causative link, but a really good question. Moving on. Question number 2, how soon after parathyroid surgery would I be able to tell if it was a failed surgery? I had surgery elsewhere a few months ago and my calcium is still over 10 milligrams per deciliter. Is it too soon to tell if it worked or not? It's a really good question. The short answer without knowing the details of the surgery, etc., is that 3 months after surgery or several months after an operation, if your calcium is measuring above 10, then you probably have persistent disease. If you are 40 or above. If your calcium levels measure over 10 and your parathyroid hormone levels are measuring anywhere above 30, really, that's consistent with persistent disease. So, review those labs of yours. If that's kind of what your biochemistry looks like now, then unfortunately you probably still have a problem. And either talk to your surgeon about it, obviously, and if you don't find any help there, then feel free to contact our center. I'd love to talk to you about it and evaluate your case. Okay, question number 3, another good one. Can ultrasound of the thyroid showing a thyroid nodule be mistaken and really this be a parathyroid adenoma? Yeah, the short answer is yes. This happens pretty commonly in my experience. If you're an experienced ultrasonographer or particularly a clinician like myself, for example, I do ultrasounds on everybody that I operate on, and I can tell the difference between a thyroid nodule and a parathyroid tumor. Number 1, parathyroid tumors are typically extrathyroidal, they're not inside the thyroid, and you can usually tell that sonographically if you know what you're doing. Sometimes parathyroid tumors can be in the thyroid, and it's easier to mistake the two, but even then, if you're experienced, you can usually tell the difference between the two, but not always. Most of the time, and I guess I would say the following. It depends a little bit who's doing the ultrasound. If you get an ultrasound done in radiology, for example, then a ultrasound tech does your ultrasound, snaps some pictures of the ultrasound, and then a radiologist looks at them later. That's a terrible way to look at ultrasound. Real-time scanning is far better, offers much more information to whoever's doing it, and so having a clinician do it is better, it's more thorough. But yeah, that's a mistake that can be made. That can lead to some things that can make surgery difficult for us. For example, if a parathyroid tumor is biopsied, that causes a really intense inflammatory reaction and makes it much more difficult to take them out. I had a patient yesterday actually who had two upper parathyroid adenomas. Both were biopsied, unfortunately, and they were incredibly difficult to remove. So it's important to be able to tell the difference on ultrasound so you can avoid some of these difficulties. Good question. Well, let's see. This question is if you have confirmed high parathyroid hormone levels and high calcium levels and are experiencing symptoms, is there any need for additional laboratory testing or imaging? I'm not sure if the question is, do you need any more testing or imaging to make the diagnosis? If that's what the question is, the answer is no. Okay. Really all you need is an elevated parathyroid hormone level and elevated calcium level. There's really no other situation that gives you that biochemistry other than hyperparathyroidism. Other testing that's commonly done, for example, a 24-hour urine calcium level, is a cumbersome test and frankly doesn't add much to the diagnosis at all. And so if you're told to get that test, you might consider not wasting your time with it. Imaging testing, getting imaging studies, that has nothing to do with making this diagnosis. Imaging technology for seeing or detecting abnormal parathyroid glands is pretty poor, even in 2024. Because of that, there's a lot of false positive results, false negative results, and so it's not useful for diagnosis. It should never be used for that. Okay, so the short answer is no, you don't need any additional testing. If you have clearly high PTH and calcium levels, that makes the diagnosis. Okay, next question. Should an individual with parathyroid disease and low vitamin D levels take vitamin D supplements? Probably we're talking about the 25 hydroxy vitamin D levels. The short answer is I usually say no. I recommend patients don't take vitamin D supplements. There's a couple reasons for that. It's normal to have a low 25 hydroxy vitamin D level when you have hyperparathyroidism. Okay? One of the things parathyroid hormone does is to convert that vitamin D to the 125 dihydroxy form. That's the more active form of vitamin D, and it facilitates absorption of calcium from your GI tract. So that's one of the things parathyroid hormone is supposed to do to help raise your calcium levels when they're too low. When you have parathyroid disease and you're overproducing this hormone, you're constantly depleting that 25 hydroxy vitamin D level, and so it's almost always low when you measure it. And that's usually what your doctor measures when they're trying to get a general sense for your vitamin D levels. Okay. Taking supplements at that point is sort of like swimming upstream, because you're fighting parathyroid hormone's conversion of that vitamin D to a different form. So it's hard to get them to come up even with supplements, and in a lot of patients who have active parathyroid disease, taking vitamin D supplements can make their symptoms worse. So I usually recommend patients to just stop taking vitamin D supplements. Typically, once the disease is corrected with surgery, vitamin D levels kind of will come up and normalize on their own in the next 4 to 6 months. Okay. Okay, next question. If you've had a 3.5 gland or subtotal parathyroidectomy for hyperplasia, is there a concern about becoming hypoparathyroid? How low is the PTH to be considered hypo? So question number one, is there concern for hypoparathyroidism when you do a subtotal parathyroid resection? I mean, if you have an experienced surgeon, then the answer is, should be no. The way you go about doing this is, first of all, you should identify all 4 glands first. Then you select a gland that will make the best remnant to leave behind. Okay. When you do that, you mobilize that gland completely so that you can see exactly where its blood supply is coming from. Once you know that, you can trim it, take some of it off safely, okay, while preserving its vascular supply. So if you're an experienced surgeon, this is not difficult to do. That's the first thing you do, and you observe that remnant gland for a period of time to make sure it stays well vascularized. Avascular or devascularized parathyroid tissue darkens really quickly. So you can usually tell within 5 minutes or so if that gland is good or not. And once you confirm that, then the remaining glands can be removed. So hypoparathyroidism is not something that we run into, in this practice when doing a subtotal resection. Technically, there's a risk for that, but if you're experienced and you go about it the way I described, it's really not a big factor, okay? How low is PTH to be considered hypo? That's a tough question to answer. PTH can be pretty low depending on the circumstance, and that can be okay. But diagnosing hypoparathyroidism usually involves the following. If your calcium levels are really low, if they are below normal, like in the 7 to 8 range, that's lower than it should be. Your PTH values are low as well, in the low single digits or 0. That's bad. And usually your phosphorus levels will be elevated. That's the classic biochemical profile for someone with hypoparathyroidism. Low calcium, very low PTH values, and high phosphorus levels. Okay. Let's see. Here's the next question. My blood work shows primary hyperparathyroidism as well as my bone scan. I'm not sure what that means really. Bone scans don't really show hyperparathyroidism. Maybe the person just means that they have evidence of bone loss. I've had an ultrasound showing a tumor, and I had one ultrasound that did not show a tumor. What scans will happen at your hospital before surgery? Well, traditionally we perform what's called a technetium system scan on all of our patients before surgery. The surgeons here all do an ultrasound of the neck, the thyroid, etc. before the operation as well. So those are the two imaging tests that are done here before the operation. It's important to know, though, for us, in this practice, the results of those imaging tests almost never changes the operation that we do. Okay, we don't use imaging results in most cases to guide the surgery or tell us what operation to perform, because we always identify all 4 glands, evaluate them all, and then determine which of them are abnormal and need to be removed. Okay, getting the scan or giving the radiopharmaceutical that's given for that scan, whether it shows anything or not on the imaging, the picture, allows us to functionally evaluate the parathyroid glands when they're identified. So that's the primary utility of the system scan that we do. Occasionally it can alert us to some unusual anatomy, and that can be helpful, but for the most part, 99% of the time, both the ultrasound and the system scan don't change the operation. Ultrasound can be really important for detecting intrathyroidal parathyroid tumors. That's probably its primary benefit in terms of guiding the surgery, so to speak. But in most cases, the imaging tests don't change what we do. Okay. Let's see. This is a good question. Is normal calcium hyperparathyroidism just as damaging to your body as the traditional presentation with high calcium? Really good question. Normal calciumic primary hyperparathyroidism is a well-described phenotype of primary hyperparathyroidism. It's less common. It's harder to diagnose because of the normal calcium levels. You have to sort some additional things out to determine that this is the case. Interestingly, there is not felt to be a big difference in the damage to the body. There's not a difference in severity of symptomatology in the 2 forms of the disease, but it's a very good question. Okay, let's see. Can an adenoma, or I'm assuming the presence of primary hyperparathyroidism, cause unexplained weight loss? My mother's lost 30 pounds over the last 2.5 years and has almost every symptom listed on your website. So I think it's important to say that, if the question is, does this mean she has the disease? Really, having symptoms, having weight loss of any kind, having bone loss, none of those things mean you have this disease. It's all based on the biochemistry. So if your mother has biochemical evidence of hyperparathyroidism, then what I would say is then yes, one of the symptoms that can be GI-related symptoms to parathyroid disease if it's present. Although it's important to clarify or to know that having hyperparathyroidism doesn't just cause weight to pile onto somebody or for people to lose weight. Just like curing the disease doesn't make weight just fall off the body. There's no direct effect on metabolism that parathyroid hormone has. Not like the thyroid, for example. Thyroid hormone does affect your metabolism directly, but parathyroid hormone does not. Having said that, yeah, you can have GI symptoms. It can affect people's appetite, and so people patients who have had pretty significant weight loss because of that. Good question. Okay, this is apparently a patient that I operated on. You removed 3 hyperplastic glands from me. What are the chances the 4th gives me trouble down the road? It's good. Yeah, it's a good question. Patients always get really nervous when you tell them that they had parathyroid hyperplasia, that you removed 3 or 3.5 of their glands. They're primarily worried about removal of all those glands. But interesting, the body doesn't know the difference between having 4 parathyroid glands or having 1 parathyroid gland. One does as good a job as 4, for unclear reasons, but that's the case. But the question really is, what's the chances of that 4th gland giving me trouble? Is it possible? Yeah, I mean, it is possible. If you have hyperplasia, then all of your glands are abnormal. However, we pretty rarely need to reoperate on people for that remnant gland when we do a subtotal resection. It's possible. I've had to do it in my career, but maybe I can count on 2 hands over 20 years how many times I've had to do that. So it's pretty unusual. The reason, because it's possible, we almost always leave an embryologic lower gland as that remnant, because those glands are easier to deal with if you have to in the future in a reoperative surgery situation. Okay, but a good question. It's well less than 1% of cases that happens. Okay, let's see. Oh yeah, that's a good question. Have you seen patients with parathyroid disease with severe fluctuations in calcium across blood draws? For example, from hypocalcemia to hypercalcemia within a short period of time, like a month? The short answer is yes. Both calcium and PTH levels can fluctuate quite a bit in people with this disease. It's a common diagnostic error that I see made, where a patient will have a high calcium and a high PTH, and the doctor will say, oh, let's recheck this to be sure, and they check another set of labs, which is reasonable. And the next set of labs looks totally normal, and they will say, oh, you're fine, you don't have a problem. That's not usually the case. Usually it's just one of these cases of disease where you see a lot of fluctuation. And so the right thing to do in that circumstance is to continue to check these labs a few more times and just get an overall sense of the pattern. Because they can, I've seen a lot of patients over my career who, when you look at the last 4 or 5 years of their lab data, it's clearly disease followed by a couple normal sets, followed by disease. And so that's a really good question. It's an important thing to keep in mind when we're evaluating people for this disease. And it's sort of a common miss or common error that I see made diagnostically. Okay, can someone have parathyroid disease and not experience kidney stone issues? Good question. Yeah, the short answer is yes, absolutely. The truth is the majority of people with hyperparathyroidism do not produce kidney stones. All of the end organ complications are variable. Okay, they're variable in their presentation. Not everybody with parathyroid disease has made severe bone loss. A lot do, but not everybody does. As I said already, not everybody produces kidney stones. Most don't, actually. Not everybody who has parathyroid disease develops renal failure, but your risk of having these things is significantly higher than the average population. So your risk for developing kidney stones is higher than mine is, for example, if you have this disease, but that doesn't mean you're going to 100% develop them, okay? Let's see, this is a quick one. What are the chances of being admitted to the hospital after surgery? That almost never happens. It never is necessary, okay? For people who have been to our website or know the practice, we perform an outpatient surgery. Patients spend about 4 to 5 hours at the hospital here for the entire process of evaluation, surgery, and recovery. Needing to be admitted to the hospital is incredibly rare. If it's necessary for whatever reason, then of course it's a real hospital. We have an inpatient ward, and it's manageable, and we can do it, but it's really, really rare to be necessary. Okay. All right, next. These are all good questions. Thank you for everybody for sending these in. Let's see. I keep wondering if, after all said and done, operation completed, etc., does this condition impact your life expectancy? Yeah, it's been shown. Okay, a long time ago, actually, it's been shown that untreated parathyroid disease will decrease your life expectancy. it's primarily because of the end organ complications that this causes with time. It's similar to high blood pressure. I use that analogy a lot with patients and try to explain what happens and why we treat this disease. But hypertension, if you don't treat it, it doesn't happen overnight, but in time, your kidneys will fail, which impacts your life expectancy. You'll have a heart attack, and you'll have a stroke, and so that's why we treat hypertension, to prevent that stuff. Similar to hypertension, it's the same concept with parathyroid disease. Your risk for renal failure goes up, your risk for stroke goes up, your risk for heart attack goes up. Because of those things, life expectancy goes down. So the short answer is if you have this disease, you should have it treated. This kind of financial question for people who are from out of the country, who don't have U.S. insurance or are considering coming here when their insurance plan refuses to cover the cost of coming here. What's the cost of having an operation here if you do not have insurance, how to pay out of pocket? I talked to the financial people in the office, and it's approximately $15,000 US to cover everything if you have surgery without insurance here. Okay, let's see. Here's a good question. After surgery, is it possible to have hyperthyroidism, and that a patient might have to lower or change their medications? I'm not sure if that means this patient already takes thyroid hormone or not, but it's a good question in general because, a small percentage of patients can experience a transient hyperthyroidism after parathyroid surgery. The reason for this is that the thyroid has to be manipulated to some degree to do this operation, to navigate around the neck and identify and evaluate parathyroid glands. So that manipulation, that retraction on the gland in some cases can cause a release of hormone into the bloodstream, sort of an uncontrolled release. And so that transiently increases your thyroid hormone levels and causes usually asymptomatic, but not always, sometimes asymptomatic thyrotoxicosis after surgery. It lasts about 4 to 6 weeks. That's the half-life of thyroid hormone, so it's a fairly short-lived situation that's easily controlled with medication to control the symptoms. If the specific question is, do you need to change or lower your thyroid medication? People who require thyroid medication don't usually experience this because their thyroid doesn't work. But if your thyroid partially works, for example, and you're on a low dose of thyroid hormone, it's possible that you might need to lower your thyroid hormone replacement therapy for a month or two after surgery because of this. Okay. Let's see. Here's another question. These are ones that are phoned in, so I haven't read these yet, so bear with me. I have elevated PTH and high normal calcium levels. DEXA scan shows worsening osteopenia. I have had 2 negative scans. Is now the time for me to address this with your center? Without knowing some of your other kind of biochemical data, etc., let's assume that you have what we would call normal calcemic primary hyperparathyroidism and osteopenia that's worsening. If that diagnosis has been established, then the scans being negative has nothing to do with whether you should be treated or not. Like I said before, for one of the other questions, imaging studies, cystometry scans, CAT scans, ultrasounds have no bearing on making this diagnosis or decision to treat a patient. So if you've been diagnosed with normal calcemic hyperparathyroidism, you have evidence of end organ complications like bone loss, then the short answer is you should have it treated. Okay. Let's see. I'm a caretaker for an 80-year-old. She has calcium over 10, but the endo won't see her. That doesn't sound great. I wonder why. Is there anything that can help at her age? If she has calcium over 10, I don't know. You don't mention PTH values, but most likely if she's hypercalcemic, that's the most likely diagnosis. But let's say she has hyperparathyroidism and she's 80. Of course, there's no contraindication to treating this at age 80 or even age 90. This has been looked at. There have been peer-reviewed studies that have looked at, is there a benefit of treating hyperparathyroidism in patients in their 80s and in their 90s? And the evidence was pretty clear that yes, there is benefit. I operate someone in their 80s pretty much every day. It's not that uncommon at all. So there's no contraindication to doing that at age 80. If your endocrinologist won't see her and you have some lab data, you don't need an endocrinologist. Just send her data to our center and we'll take a look. Okay, the short answer is she should be treated if she has it, okay? And okay, that went by pretty fast. I guess we're out of time. Thanks to everybody for joining. I hope answering these questions was helpful to the people who sent them in, and then to everybody else who joined. We'll do this again in about 6 weeks or so, and I look forward to seeing you again, okay? Have a great day.